Welcome to Medical Nursing Unit, Neurological Disorders. The first disorder is headache or cephalgia. Headache is among the most common reasons that patients seek medical attention. We classify primary headache and secondary headache. In primary headache, this is the headache and its associated features are the disorder in itself. There are no other associated factors or associated disorders that is causing headache. You feel headache, only headache, without having another pathology. We can have migraine, tension type, exertional type. When secondary headache, those are headache caused by exogenous disorders. We can say systemic infection, head injury, vascular disorder, subcranoid, hemorrhage, and brain tumor. Those other pathologies that can cause headache. That headache will be classified in the secondary headache. Headache symptoms that suggest a serious underlying disorder. When you feel headache and you express or you feel those symptoms, this headache will suggest a serious underlying disorder. The headache will be severe, subacute worsening over days or weeks, fever or unexplained systemic signs, vomiting that precede headache, pain induced by bending, lifting, cough, pain that disturbs sleep or present immediately upon awakening, non-systemic illness, onset after age of 55, pain associated with local tenderness, region of temporal artery. Those signs will show a serious underlying disorder of headache. Secondary headache. We can say meningitis. The meningitis is acute severe headache with stiff neck and fever suggests meningitis. During meningitis, you will have a severe headache and also stiff neck. When we have stiffness, means that you can't turn. When you want to turn your neck, you feel pain. Here in meningitis, the lumbar puncture is mandatory to diagnose if there is to diagnose the cause of headache. Often there is striking accentuation of pain with eye movement. Meningitis can be easily mistaken for migraine in that the cardinal symptoms of pervasive headache, photophobia, nausea, and vomiting are present. Intracranial hemorrhage. This is acute severe headache with stiff neck but without fever. Suggests subarachnoid hemorrhage. You see the difference between the headache in meningitis. You feel a fever also in meningitis, but intracranial hemorrhage, this is severe headache with stiffness but no fever. Brain tumor. The head pain is usually an intermittent tip, due arching of moderate intensity, which may worsen with exertion or change in position and may be associated with nausea and vomiting. When you have a tumor, you will have a headache which may worsen with exertion or change in position and may be associated with nausea and vomiting. A history of amenorrhea should lead one to question whether a prolactin secreting pituitary adenoma is the cause of headache. Head pain appearing abruptly after bending, lifting, or coughing can be due to a posterior fossa mass. You can see brain tumor also can cause headache. When someone is suffering from headache, you have to exclude all secondary pathologies. Temporal arthritis. The temporal arthritis head pain may be unilateral or bilateral and is located temporarily in 50% of patients, but may involve any and all aspects of the cranium. This is temporal arthritis now. Head pain may be unilateral or bilateral and is located temporarily in 50% of patients, but may involve any and all aspects of the cranium. The pain is usually superficial, external to the skull, rather than originating deep within the cranium. For temporal arthritis, now the pain is usually superficial, external to the skull. Yeah, you can see sometimes when you assess the head, the skull, the scalp may be tender or pain by palpation. This will be called temporal arthritis headache. Scalp tenderness is present, often to a marked degree. Brushing the hair or resting the head on a pillow may be impossible because of pain. Now, the scalp is painful. Headache is usually worse at night and often aggravated by exposure to cold. Yeah, this headache will be called temporal arthritis. Glaucoma. The glaucoma may present with a prostrating headache associated with nausea and vomiting. The headache often starts with severe eye pain. On physical examination, the eye is often red with a fixed, moderately dilated pupil. Okay. Primary headache syndrome, migraine. The migraine is usually an episodic headache that is associated with certain features such as sensitivity to light, sound, or movement. Nausea and vomiting often accompany the headache. When you will feel headache, and the headache is severe and associated with those features, sensitivity to light, photophobia, sound, and movement, nausea and vomiting, this headache will be classified as a migraine. It is a migraine, but while we excluded other pathologies. The symptoms accompany severe migraine attacks: nausea, photophobia, lightheadedness, scalp tenderness, vomiting, visual disturbance, paresthesia, vertigo, alteration of consciousness, syncope, confusional state, and diarrhea. Those are the signs that can accompany migraine attack. If you will feel headache, you feel nausea, photophobia, lightheadedness, scalp tenderness, and vomiting, visual disturbance, while there is no other associated symptoms of secondary pathology, these will be classified as headache. Headache can be initiated or amplified by various triggers, including looking angrily, bright light, sound, hunger, excess stress, physical exertion, stormy weather or barometric pressure change, hormonal fluctuations during menses, lack of or excess sleep, and alcohol or other chemical stimulation. These also will be those signs will show the migraine. Diagnosis and clinical features. Simplified diagnostic criteria for migraine. This is repeated attacks of headache lasting 4 to 72 hours. In a patient with a normal physical examination, no other reasonable cause for the headache, and at least 2 of the following features: unilateral pain, throbbing pain, aggravation by movement, moderate or severe intensity, plus at least 1 of the following features: nausea, vomiting, photophobia, and phonophobia. Yeah, those are the diagnoses of the migraine. Acute attack therapies for migraine. Most drugs effective in the treatment of migraine are members of one of 3 major pharmacological classes that we will see in special pharmacology: anti-inflammatory agents, serotonin receptor agonist, and dopamine receptor antagonist. Anti-inflammatory agent, you can say ibuprofen, naproxen, terifenamic acid, combination of acetaminophen, aspirin, and caffeine. Dopamine antagonist, now metoclopramide, chlorpromazine also will be used. Now, let's see the type what we call tension type headache. Tension type headache. The term tension type headache is commonly used to describe a chronic head pain syndrome. This is describe a chronic head pain syndrome characterized by bilateral tense, tight discomfort. Yeah. The pain typically builds slowly, fluctuating severity, and may persist more or less continuous for many days. The headache may be episodic or chronic, present over 15 days per month. This will be chronic head tension type headache. Headache of tension type is not accompanied by features such as nausea, vomiting, photophobia, phonophobia, osmophobia, throbbing, and aggravation with movement. Yeah, this will be a chronic pain. You will feel pain and come continuously for many days. The treatment for tension type pain, the pain can generally be managed with simple analgesics such as acetaminophen, aspirin, or other. Behavioral approaches, including relaxation, can also be effective. For chronic tension type headache, give amitriptyline. For those chronic pain, we give amitriptyline. This is the headache without those signs of vomiting and photophobia, and nausea. This will be tension type headache. Okay, this is chronic. It comes more days. Now we will give amitriptyline. Let's see. Cerebrovascular accident, stroke syndrome. Any abnormality of the brain caused by pathologic process in the blood vessels is referred to as a cerebrovascular disease. The common clinical manifestation of cerebrovascular disease is a cerebrovascular accident, also called stroke. A stroke is defined by the abrupt onset of a neurological deficit that is attributable to a focal vascular cause. Cerebrovascular accident includes ischemic stroke or hemorrhagic stroke. This is a condition in which affect the vascular, cerebrovascular, the vascular in the brain, the vessels in the brain. The vessels in the brain that can cause the absence of the supply, deprivation of blood supply, or hemorrhage. We can say ischemia or ischemic stroke, and hemorrhagic stroke. We will say ischemic stroke when there is a temporal deprivation of the blood supply in one part of the brain. And hemorrhagic, this is the rupture of the vessel in the brain. The risk factors for the stroke syndrome or the cerebrovascular accident is hypertension, atherosclerosis, old age, over 65 years, smoking, diabetes, polycythemia and thrombocythemia, hypercholesterolemia. Okay, those are the risk factors that can cause cerebrovascular accident or stroke. Let's see stroke, ischemic stroke. Cerebral ischemia is a condition in which there is a reduction in the blood flow that lasts longer than several seconds. This is a reduction in blood flow in the brain that can be longer than several seconds. It is not several minutes, but it is several seconds. We have transient ischemic attack. When the blood flow is quickly restored, the brain tissue can recover fully and the patient's signs and symptoms resolve within 24 hours. Here, for transient, this is at a short time attack. You can have a deprivation of the blood supply in the brain at a short time. Here, you will show the symptoms, but you will recover. The symptoms will resolve within 24 hours. Stroke in evolution. Progressive stroke. Stroke in evolution. This is the progression of neurologic deficit of hours to days. Means the symptoms come progressively. So you can have ischemic stroke. Now means the progressive deprivation of blood supply in the brain. Complete the stroke, the cerebrovascular accident that has reached its maximum destructiveness in producing neurologic deficit. Here there is a total now, a complete stroke. This is the maximum destructiveness in of neurologic deficit now. Okay. Causes. The causes of ischemic. This is we can have thrombotic stroke, thrombosis. The thrombosis, this is the occlusion of the vessels in the brain by the thrombus. Large vessels thrombosis, cerebral thrombosis occur when arteries supplying the brain or the intracranial vessels are occluded by thrombi. Yeah. Lacunar stroke or lacunar infarct. This involves the small vessels in the brain. It will be lacunar stroke when the clot involves the small vessels, while it will be thrombosis when we call large vessel thrombosis. The large vessel thrombosis, this is a large artery with artery supplying the brain with the artery. But when it is small veins, small vessels will be called lacunar stroke. Emboli involves fragment that breaks from a thrombus formed outside the brain in the heart, aorta, or carotid. The embolus usually involves small vessels and obstruct them. Here we can say during emboli, the clot can come from the other parts, especially in the legs, and it can go in the blood circulations, entering the heart pump. And it go in the lungs, it comes in the heart, and the heart pump also, and it goes up in the brain. That will be the small one, and will obstruct the smaller capillaries in the brain and cause a deprivation of the blood supply. Pathophysiology. Acute occlusion of an intracranial vessels causes reduction in the blood flow to the brain region it supplies. The fall in cerebral blood flow to zero causes death of the brain tissue within 4 to 10 minutes. You can see when the brain lacks the blood, within 4 to 10 minutes the cells die. The blood flow inferior to 16 to 18 ml per 100 gram tissue per minute causes ischemia without infraction unless prolonged for several hours or days. When the blood flow superior to 20 ml over 100 gram tissue per minute, it will cause infraction within an hour. No glucose supplying the neuron, no production of the ATP by the mitochondria, membrane ion pump stop functioning, neurons depolarize, intracellular calcium rises, glutamate releases, neurotoxicity, and cellular death. So the glucose is very important in the brain. Whatever you do, please do that your brain be supplied by glucose. That's why hypoglycemia, it is a severe disease, severe conditions to save immediately. You can see, and we have to do all possible that the blood can reach in the brain, because glucose, either oxygen are carried by the blood. That's why hypotension should be avoided for all patients. Diagnosis: a complete neurologic examination to localize the site of stroke, and the CT scan or MRI based angiography to examine the neck and the intracranial vessels. A chest X-ray, electrocardiogram also should be done to exclude to diagnose ischemic stroke. Let's see hemorrhagic stroke. Causes of hemorrhagic stroke. The first cause is hypertension. This is really what we call a cerebrovascular accident in the general term. This is the main cause. Hypertension is the general cause of hemorrhage. Hypertensive hemorrhage is associated with significant increased systolic diastolic pressure over several years and usually occurs in the brain tissues. Most and many people are killed by the hypertension, and it is a silent killer. Means what? It can cause hemorrhage, stroke hemorrhage slowly in the brain. Now, the lateral aneurysm can cause it. This is the rupturing of the artery. A vascular malformation can cause and bleeding into a tumor. Hemorrhage is associated with bleeding disorders and head trauma. Yeah. Most of the time, the clients are dead from hemorrhagic stroke. Here, that's why we have to exclude, to screen for a hypertension disease to avoid those complications. This is the complications, and it kills many people. Pathophysiology of hemorrhagic. This is the primary cause of cerebral hemorrhage is hypertension. The hypertension involves the smaller arteries and arterioles, resulting in the thickening of the vessels wall and increased cellularity of the vessels and the hyalinization. Necrosis may be present. There is a spontaneous rupture of the smaller vessels or arterioles that precipitate the bleeding. A mass of blood is formed as the bleeding continues into the brain tissue and form hematoma. Yes, and the hematoma will compress the adjacent brain tissues, then producing ischemia, edema, and increased intracranial pressure. The rupture or escape of blood into the ventricular system often occur. Okay, this is the pathophysiology of the hemorrhagic stroke. The manifestations, the clinical manifestations vary depending on the location and the size of the bleed. The following are considered to be symptoms of a stroke and require immediate interventions. Now, if you see the client with visual change and sudden change in vision, loss of vision, decreased vision, please try to think about hemorrhagic stroke. And the sensation change, numbness, tingling, decreased sensation, abnormal sensation, movement change, weakness of any body part, difficulty moving any body part, loss of fine motor skills, difficulty speaking or understanding others. That can show that there is the hemorrhagic stroke. Difficulty swallowing, difficulty reading or writing, loss of coordination, loss of balance. Okay. We can have surgical activities of any type. Headache when lying flat. A headache that makes the person up. A headache that increases with change of position. When you bend and straining, coughing, and you feel pain. Decreased level of consciousness. Apathetic, withdrawn. Sleepy, lethargic, stuporous, unconscious, or comatose. That will also we also show the hemorrhagic stroke. The treatment The control of the risk factor, it is the first, lowering the blood pressure, antiplatelet agent, aspirin in case of thrombolytic stroke, anticoagulation, heparin to prevent further embolization and correcting the primary problem. In the case of intracranial hemorrhage, stop or reduce bleeding. Yeah, reduce bleeding, stop. Controlling increased intracranial pressure, preventing a cerebral and vasospasm, neurosurgery to evacuate or aspirate the blood. Let's see the seizures and the epilepsy. The seizures and the epilepsy. What do we call igituri? Sometimes it's igituri, around convulsions like this. And the seizures, it is a sudden, explosive, disorderly discharge of cerebral neurons in the E and the. It is characterized by a sudden transit alterations in the brain function, usually involving motor, sensory, and autonomic or psychiatric clinic manifestations, and alter the level of arousal awareness. The seizure, it is caused by the electrical conductions in the brain, now from first hemisphere to another hemisphere. So now, when that conduction is excessive, now it comes to stop the brain functioning. There is a brief disruption in the brain electrical function. Those electrical function in the brain, when it becomes misconducted, they disturb the brain functioning and cause seizure. A convulsion, a term sometimes applied to seizure, refer to the jerky, contract, relax, tonic, clonic movement associated with some seizures. The convulsion now is when it's like a trembling now. This is jerky, yeah. Epilepsy is a condition for which no underlying correctable cause for the seizure can be found. Therefore, seizure activity occurs without treatment. This is usually gisanzwe. What do we know? We will call it epilepsy when it is a condition for which no underlying correctable cause for the seizure can be found. Therefore, seizure activity occurs without treatment. And when we don't give the treatment, the seizure occurs. Okay, now this is usually the condition is known to be chronic, and the seizure are recurrent. This is typical usually epilepsy. What etiologic factors in seizures generally include cerebral lesion. This is the congenital malformation, infections like meningitis, brain tumor, vascular disease, febrile disease, biochemical disorders, metabolic defects like hypoglycemia, hypocalcemia, drugs and alcohol abuse, cerebral trauma, epilepsy also, genetic predisposition. Those are etiological factors in seizure. Donc, cerebral lesion can cause seizure. Those meningitis, brain tumor can cause seizure. Vascular disease, and even febrile disease, especially in infants now, for the fever. If the infant have a fever for higher degree, he can develop the seizure. And biochemical disorders like metabolic defects like hypoglycemia, hypocalcemia, drugs and alcohol abuse can also cause seizures. Cerebral trauma and epilepsy usually gisanzwe. Cause of recurrent seizure in a different age group in neonate under 1 month, perinatal hypoxia and ischemia. Yeah, when you take the neonate is having hypoxia can cause seizure. Intracranial hemorrhage and trauma, acute central nervous system infection, metabolic disturbance like hypoglycemia, hypocalcemia, hypomagnesemia, pyridoxine deficiency, drug withdrawal also can cause seizure. Infant and children over 1 month and under 12 years. Developmental disorder can cause seizures. Genetic disorders, febrile seizures, genetic disorders, metabolic degenerative primary epilepsy syndrome, central nervous infection, developmental disorder, trauma, idiopathic now. Sometimes the infant can have the idiopathic seizures. Now, those are the cause of seizures. For adolescents, Trauma can cause seizures, genetic disorders, infection, brain tumor, illicit drug use, idiopathic also can cause seizures for adolescent. Okay, young adult, 18 to 30 years old, trauma, alcohol withdrawal, illicit drug use, brain tumor, and idiopathic also. For all the adult cerebrovascular disease, most of the time for those elderly adult, now for all the adult, the cerebrovascular disease can cause the seizure, brain tumor, alcohol withdrawal, metabolic disorder, uremia, hepatic failure, electrolyte abnormalities, hypoglycemia, Alzheimer's disease, and other degenerative central nervous system disease, idiopathic also can be the cause of seizures. Classification of epileptic seizure, partial seizures, the partial seizures, and generalized seizures. It will be called partial seizures. This will occur within a discrete region of the brain. There is involuntary movement of the contralateral part of the body, like hands, leg. The movements are usually chronic, sometimes tonic. This is partial seizures. There we have involuntary movement of the contralateral part of the body. When we say the contralateral part of the body, we will understand hands and leg. And the movement will be chronic and sometimes tonic. The partial seizure occur within a discrete region of the brain. Okay, this is a repetition, of course. Now, generalized seizure, we call absent seizure, petit mal, generalized seizure, tonic-clonic seizure, grammar. Absent seizure, petit mal. The absent seizure are characterized by sudden, brief, a sudden, brief relapse of consciousness without loss of postural control. Here is when the client should lose the consciousness at a few moments, few time, without losing postural control. The postural control, this is the movement of the legs and the arms. The seizure typically lasts for only seconds. Now, it can't last a long time. Consciousness returns suddenly and it was lost, and there is no post-echo confusion. Although the brief loss of consciousness may be clinically inapparent, absent seizure are usually accompanied by slight bilateral motor signs such as a rapid irregular movement of the eyelid, a shadowing movement, or small amplitude chronic movement of the hands. Okay, this is small. This is absent seizure. Petit mal. Ahangaha umuntu atakaza ubwenge akanya gatoya hanyuma akagarura ubwenge, ariko ko kanya ushobora nko gusanga nk'amaso arimo gutitira, tugana dutitira bukeya. This is absent seizures. But for generalized tonic chronic seizure, this is igicuri gisanzwe. Primary generalized tonic chronic seizure are the main seizure type in over 10% of all persons with epilepsy. They are also the most common seizure type resulting from metabolic derangement and are therefore frequently encountered in many different clinical settings. This is generalized or grammar, igicuri. Let's see the phase of grammar. There is a phase of the grammar, how it develops. First step is a prodroma phase. Early clinical manifestations such as malaise, headache, or sense of depression that may occur hours to a few days before the onset of a seizure. For those who experience the seizure, when you ask them, they can even say when the seizure is about to happen, they feel it. They can feel headache. They can see sense of depression. While you are explaining to the client with the epilepsy, you can even try to identify the signs and the symptoms of primordial seizure. This is the prodroma phase. Oral phase, peculiar sensation that immediately precedes the onset of generalized seizure and may take the form of gustatory, visual, or auditory experience, or feeling dizziness, numbness. This is the In the oral, the client feel gustatory, gustatory. They can't feel or visual, auditory experience or feeling a dizziness now. And now numbness. There he feel now he feel numbness and experience dizziness in Kizungerera. This is the condition that immediately precedes the onset of generalized seizure and may take the form of visual and auditory experience. Kwa yumva ibintu bidasanzwe yareba n'ibitaboneka and akagira dizziness and numbness. This is the oral phase. Now tonic phase. The tonic phase is the tonic contraction of the muscle or of expiration, and the larynx at the onset will produce a loud moan or ecto cry. Tonic phase, the tonic contraction of the muscle. This is the tonic, the movement. The respiration are impaired. Secretion pool in the oropharynx, and cyanosis develops. Contraction of the jaw muscles may cause the beating of the tongue. Here the cat can also beat the tongue. A marked enhancement of sympathetic tone lead to increases in heart rate, blood pressure, and pupillary size. The duration of this phase range between 10 to 20 seconds. This is associated with loss of consciousness. Okay, this is igichuri amaze kugwa. This is a tonic phase. Chronic phases after 10 to 20 seconds. The tonic phases of the seizure typically evolves into the chronic phase with alteration of contraction and relaxation of muscles. This phase lasts no more than 1 minute. This is the relaxation of muscle. You have seen those with injury, they have a tonic phase, and then after the contraction stops and there is a relaxation. Okay. This relaxation phase, the time period immediately following the cessation of seizure activity. It is characterized by the muscle relaxation and excessive salivation that can cause stertorous breathing and the partial airway obstruction. Bladder or bowel incontinence may occur at this point. Patients gradually regain consciousness over minutes to hours, and during this transition, there is typically a period of postictal confusion. Patients subsequently complain of headache, fatigue, and muscle aches that can last for many hours. Okay, this is the postical or relaxation phases. For this, the muscle will be relaxed. But we can have excessive salivations and the partial airway obstructions because those excessive salivation and the bladder ubona ko binyarira bashobora no kwitumaho. There's a bladder and the bowel incontinence may occur, and then after they can complain headache, fatigue, and muscle aches that can last for many hours. To diagnose, use EEG, basis, electroencephalic gram in the essential exam. Exam to rule out the cause of CT scan, lumbar puncture, blood test can be done to rule out the cause of the seizure. And the treat the cause if identified. Antiepileptic drug can be given for those with the chronic epilepsy. Education, recognition of signs and symptoms of prodroma and aura, so that the patient may avoid the fall in a very risk area. This is the education you have to give to the client that experience epilepsy. You have to educate them. The recognition of signs and symptoms of prodroma and aura. That is to protect the patient for injury. You have seen that many patients with epilepsy, they experience burns where they are cooking, they fall into the fire. So we have to teach them to know prodroma and other signs. Avoid driving, working with the machinery, working at heights, swimming, and other activities that may cause serious injury. Psychosocial support, counseling to minimize depression, anxiety due to social stigmatization, lack of job, frequent hospitalization. Those people need the psychosocial support, of course, the counseling. because if the person is known to be epileptic in the community, is stigmatized, isolated. So we have to provide this psychosocial support. Let's study unconsciousness and coma. What is unconsciousness? Unconsciousness is the state in which the client is unresponsive to sensory stimuli and lacks awareness of self and environment. Unconsciousness, the person is unresponsive to stimuli, sensory stimuli, and he lost the awareness of self and even environment. For a client who is in unconsciousness, she can't determine where she is or the time, like that one. Unconsciousness can be brief, lasting a few seconds to a few hours or longer. To produce unconsciousness, a disorder may disrupt the reticular activating system, which extends up to the thalamus, significantly disrupt the function of both cerebral hemispheres, metabolically depress overall brain function. Coma. The coma, this is a prolonged state of unconsciousness in which the client is unaware of self or the environment for sustained periods of time, for hours to months. Okay, when unconsciousness becomes to be at a long time, from hours to months, this is a coma. The word coma comes from the Greek word coma, meaning deep sleep. Yeah, you can see when the client is in coma is as such is in the deep sleep. Coma is a state in which a patient is totally unaware of both self and external surroundings and unable to respond meaningfully to external stimuli. There may be a momentary unconsciousness due to concussion. The prolonged period of unconsciousness is called coma. The coma is prolonged period of unconsciousness. In few words, what can cause the coma? Intracranial causes. You can have supratentorial region above the cerebellum, and tentorial disorder involves cerebellum and brain stem, hematoma, neoplasm, ischemia, or infarct. Extracranial causes may be metabolic disorder or toxin, hypoxemia, hypercapnia, hypocalcemia, hyponatremia, hypotension, blood sugar tension, liver dysfunction, fluid electrolyte disorders, multi-organ dysfunction, drug effect, infection, and toxin. Those may be extracranial causes of the coma. Yeah, you can see, you will read. Clinical manifestations. Altered consciousness. Level of altered consciousness. We have the different levels. The first is the confusion. Confusion, this is the loss of ability to think rapidly and clearly, impaired judgment and decision making. This is the first level of altered consciousness. You see the status of the client may be confusion. The client will be confusion when he lost ability to think rapidly and clearly, and impaired judgment and decision making. Disorientation. When we say that the client is disoriented, beginning loss of consciousness. Disorientation to time, followed by disorientation to place and impaired memory, loss of self-recognition. Now, this is disorientation. This is the beginning of loss of consciousness. The client will be disoriented to time and disoriented to place, and will have impaired memory. He cannot remember the date when he has hospitalized, how he arrived, he can't remember. Loss of self-recognition. Okay. Lethargy. The lethargy is third level of unconscious of lethargic consciousness. Now, lethargy, they can't really limit the spontaneous movement or speech. That we call the lethargy. They limit the spontaneous movement or speech. Abutandation. Abutandation now merely to moderate reduction in arousal awareness with limited response to the environment. For asleep, unless stimulated verbally or tactilely. Answers question with minimum responses. Here we obtundation. This is the state in which the client will have limited response to the environment. And for sleep, unless stimulated verbally or tactilely, and they will answer questions with the minimum responses. Here we'll say the client state is the obtundation. The level of stupor. The stupor is the condition of a deep sleep or unresponsiveness from which the person may be aroused or caused to open eyes only by vigorous and repeated stimulation. Response is often withdrawal or grabbing at stimuli. This is stupor now. In the stupor, the client is unresponsive from which the person may aroused or caused to open eyes by vigorous stimulation. We will call it stupor. And coma, the non-verbal response to the external environment or to an stimuli, noxious stimuli such as a deep pain or suctioning, don't hear the motor response. Okay, in the coma, the client will not show any response when we stimulate. And we have right coma. The right coma associated with the purposeful movement on stimulation. You had a right coma when you stimulate the client and try to move, and coma associated with non-purposeful movement only on stimulation, and the deep coma associated with the unresponsiveness or no response to stimulation. You can see that is a right coma, and a deep coma. A right coma, the client we purposeful movement, we have some movement on stimulation. But coma, the client will have a no purposeful movement, or only on stimulation. While in the right coma, the movement is purposeful. In coma, there is non-purposeful. And deep coma, there is unresponsiveness or no response to any stimulus. You can see to differentiate those terms, and we will use them in the clinical practice. Yeah, breathing pattern. You can have Chinese talk respiration, hyperpnea, apnea, hyperpnea, apnea. This is Chinese stroke respiration. Apneic respiration may be present. Donc, this is end inspiratory pause of 2-3 seconds, alternating with end expiratory pause, and bradypnea, gasping breathing pattern, agonogasp. Yeah, now. A papilla change, because the brainstem area that control arousal are adjacent to area that control the pupils. The papillary change indicate the presence and level of brainstem dysfunction. Yeah, we have dilated and fixed pupils. Oculomotor response, eye movement change, impaired eye reflex. Yeah, this is the signs of coma. Motor response. The motor response may be purposeful, inappropriate, may not present. We have decorticate rigidity, flexion of upper extremity, what you call decorticate rigidity. There's a flexion of upper extremity, and decerebrate posturing rigidity. There's extension response in the upper and the lower extremities. What we call flaccid state, with little or no motor response to stimuli. That flaccid state, the client may be already there. But let's see the How we evaluate the coma? With Glasgow Coma Scale will help in evaluating your level of consciousness. CT and MRI also, lumbar puncture, and the laboratory test can evaluate. For other assessment, it is what we call decorticate posturing and decerebrate posturing. During decorticate posturing, legs and feet extended with plantar flexion and arms rotated and flexed on the chest. While decerebrate posturing, arms stiffly extended and hands turned outward and flexed. Legs also extended with plantar flexion. The outcome fall into two categories: mortality and the extent or disability or morbidity. We have brain death. The brain is damaged so completely that it can never recover and cannot maintain the body's internal homeostasis. It is irreversible cessation of function of the entire brain, while somatic function is maintained by artificial means and the heart continue to pump. Yeah, the brain can deaf. This is the death of the brain, but the heart continue to pump. It is irreversible cessation of function of the entire brain, while the somatic function is maintained, but it is an ability to maintain the body internal homeostasis. Yeah. Criteria for brain death: comprehension of all appropriate and therapeutic procedures. Yeah. Unresponsive coma. No spontaneous respiration. No ocular response. Ischemic. Confirming test indicating absence of cerebral secretion. Now, this is criteria for brain death. This is the comprehension of all appropriate and therapeutic procedure. Unresponsive coma. Okay. This is a death. Cerebral death. This is irreversible coma that consists of death of cerebral hemispheres, exclusive of the brain stem and cerebellum. The individual is forever unable to respond behaviorally in any significant way to the environment. The brain may continue to maintain internal homeostasis. The survivor of cerebral death may remain in a coma or emerge into a vegetative state. In a coma, the eyes are usually closed with no ear opening, and the person does not follow command, speaks, or have voluntary movement in cerebral death. What is the management of coma? The immediate goal in the comatose patient is the prevention of further nervous system damage, like hypotension, hypoglycemia, hyperglycemia, hypercalcemia, hypoxia, hypercapnia, and hyperthermia should be corrected rapidly. Treat other causes accordingly. An oropharyngeal airway is adequate to keep the pharynx open in drowsy patients who are breathing normally. Tracheal intubation is indicated if there is apnea, upper airway obstruction, hypoventilation, or emesis, or if patient is unable to aspirate because of coma. This tracheal intubation is indicated. IV access is established. The urinary catheterization also. Continue to assess the depth of coma using Glasgow Coma Scale. Prevent complications, and IV antibiotics are given to prevent infection such as pneumonia, UTIs, and others. Now, this is the management of the coma. Maybe if you read, you will understand it very well. What is nursing management? Change the current position every 2 hours to relieve skin pressure, to prevent pressure sores, and facilitate drainage. Turn client gently because they cannot verbalize pain. Yeah. The client in the coma have to be changed in position. Elevate the head end of the bed to 30 degrees to prevent aspiration. Suction airway as needed to provide a clear airway and prevent the development of pneumonia. Remove dentures. Use special beds to prevent pressure on bony prominences. Provide massage to prevent pressure sores. Those are the nursing care for a patient in a coma. Yeah, we elevate the head end of the bed. Suction airways. Provide massage to prevent pressures. Change the current position and give exercises. Provide the passive range of motion exercises. Assess the neurologic status in the first few hours of coma. Insert a nasogastric tube for feeding. Never give fluid orally. Food place the client at risk for aspiration. Facilitate enteral feeding. Provide oral care at least twice daily. Provide oral care at least twice daily. IV line and administer prescribed fluids. Administer prescribed drugs. This is nursing care. Administer prescribed oxygen. Collect blood and urine sample. Insert an end-wearing catheter in case of urinary retention or incontinence. Condom catheter for male and absorbent pads for female in case of an incontinence is alternative. So we can't maintain to use the urinary catheter because it can cause infections. If possible, please use condom catheter for male and use pads for female. Monitor vital signs, oxygen saturation, and record. Ensure comfort care, bed bath, bed making. Support the client in toileting. Use bedpan or diapers pads if available. Assess fingernail and toenail for length and cleanliness. Assess the client's skin and insist on bony prominences for the absence or presence of redness, dryness, or breakdown. Monitor intake and output strictly. Provide safety of the client by always keeping the sides lay up. Take care to avoid any fall and injury. Do not restrain the patients. Restrain only unless absolutely necessary. If with restraints, check for skin integrity and adequate circulation. Reassure the family. Proper communication. Always address the client by name. And explain the procedure each time. However, if the client is in a coma, but please, before doing anything on the client, please communicate. Do not consider that he is not understanding. Communicate. You tell the client, my name is Adrian, I want to give you an injection. Okay. Thank you for your good attention.